Hello and welcome to It's Personal, the podcast about putting the citizen at the heart of public service transformation. I'm Jess, Editor-in-Chief of Civil Service World.
And I'm Jo, a partner at KPMG, and I focus on customer transformation. Lovely to be back with you, Jess. Today's guest has given us a lot to get into. We're talking about AI in the NHS, which of course is a massive topic, but this conversation takes it somewhere really specific and I think genuinely impressive.
Absolutely. So for today's podcast, I spoke to Rob Dale, who is a Senior Programme Manager for Digital Diagnostics and AI at NHS England, and he leads the AI Diagnostic Fund, which is a £21 million programme that has deployed AI tools into imaging services across 64 NHS trusts. Jo, did you know that 1 in 3 chest x-rays in the NHS is now supported by AI?
Well, do you know, some of my health colleagues, I'm sure, do know that, but I did not know that. And it is absolutely astonishing. And, you know, what I find so interesting about AIDF is that it's a great success story. You know, you hear a lot about little AI pilots running and never really going anywhere, which is equally important because it's important that we innovate and learn and experiment. But this one has really worked. And to be able to take it to the scale that it's now at is just fantastic.
It's amazing. And Rob and I get into all the factors that went into that, including things like the balance between central and local control when you're implementing a big change program, and also how you bring staff with you when you are asking them to trust a new kind of technology. And Jo, I imagine that you work with a lot of leaders who are wrestling with exactly those kinds of questions when they are managing change.
Yeah, it's a common question and a common thing that we talk about. I think one of the things that I'm really curious to learn more about is the patient experience. So, you know, this innovation is amazing, but ultimately, this podcast is all about the impact on citizens, customers, patients. So, you know, when AI flags a chest x-ray as urgent and someone gets their results the same day rather than waiting a week, that's hugely significant for a human being's life.
It's a person's life rather than just a statistic, isn't it? And Rob has got a brilliant story about that. I won't give it away, but it really does bring home what we're always banging on about on this podcast about putting the citizen at the heart of things. So with that in mind, here is my conversation with Rob Dale, which began with me asking him what he does and where AI fits into his work. Welcome, Rob, to It's Personal. I was going to start by asking you to explain your role to our audience of civil servant listeners who might not have any knowledge of pathology or digital diagnostics.
Yeah, sure, no problem, Jess. I work for NHS England, which is the central body that oversees all of the work across the NHS. Within there's obviously lots of different national programmes that run, and I've worked for just over, about 4.5 years now on programmes which are looking at digitisation work in diagnostics. Diagnostics is a very kind of broad term. It covers all of those kind of tests that you might have in order to form a diagnosis. When you potentially go and see a consultant at the first time, or you go and see your GP, they might say, okay, we need to perform this kind of test or in order to help us get some better understanding about what's going on with the patient. So, you know, that might be medical imaging, it might be blood tests, it might be, you know, biopsies. There's a number of different areas. And in those last few years, we've been working and investing quite a significant amount of money into digitising those kind of areas. So you might have seen that best if you've ever gone for an X-ray in the last few years, whereas before it used to output this film that went up on a big light board on the wall. Now they take a digital image and it appears on the computer screen. So it's a similar sort of approach that we're taking, is to have that digital capability in diagnostics areas. For the last 3 years, I've been leading on the implementation of artificial intelligence into diagnostics.
So that it was a Sunak era thing, wasn't it?
It was Steve Barclay was the one who was the health secretary at the time who announced it. And obviously there was a period of time where we've had lots of different health secretaries and prime ministers back then, but it's been running throughout that period and across obviously the changing government between Conservative then to Labour as well. And we set out with a goal of trying to implement an AI capability into 40 to 50 trusts. We've kind of been doing that for the last few years, looking to put in a type of AI to gain some experience, to see how people are, to understand the benefits potentially around it and the impact that it has on a specific service that we were looking for. We targeted the lung cancer pathway. Mm-hmm. It's the one with the most deaths per annum. The mortality rates are highest out of all of our cancers.
We've had the background, but because we are called It's Personal and we're all about citizen experience, I wonder if you could share the story of a real patient whose experience has genuinely changed because of the AI Diagnostic Fund.
Yeah, sure. The two types of tools that we've put in are X-ray tools and CT tools. And a CT is just a whole load of X-rays that are taken at a time in order to make up a 3D image. Mm. The first instance of the AI being used, it does the first review and looks at that image. So in effect, they are scanning, very similar to the way that a human eye would look at an image. They're scanning the image and they're looking for the imagery that's there down at a pixel level to say, is it seeing anything that kind of looks abnormal compared to what it would expect based on the data on which it's been trained? But it also has an idea of what those differences might be based on its data set. It's then looking and saying, can I match what I'm seeing against something that I know looks different? And then in effect, what does that fundamentally mean? But the idea is that the AI can kind of almost order everything. So in the past, it would have been the first available reporter reports the first available image. What we wanted to try and do was to make it shorter between them having the referral and potentially having a discussion about treatment. So we were really keen to see if we can speed up that process using AI to try and make it so that, the patients get an outcome sooner and have those discussions sooner. And obviously, there's no magic element to this that it's going to, rapidly shorten it and change something. But even if it's just an incremental change in small measures across the pathway, it's still making a significant difference for a patient. The idea is that the human then goes in and reports their image because we need a clinical diagnosis from someone who's been trained and experienced in this. But they are supported by the findings of the AI. Now that we've got all of our chest X-ray tools fully implemented, a third of all the X-rays, chest X-rays in the NHS are now being supported by AI tools.
That's sort of staggering, actually.
Yeah, so we got some numbers back the other day. 3.2 million chest X-rays have been augmented by AI since we've put this in. So really quite high numbers. Just to answer your question about an impact it's had on a patient, there was a really good example that we saw up in the Northeast. And it actually happened on the day that they turned on their AI. Typically, they would usually take somewhere in the region of about a number of days, almost a week maybe, to report their findings and output from an example. But they had a patient who attended for a chest X-ray in the morning. His X-ray scan was one of the very first ones that went through the AI tool that flagged it as something that needed to be looked at as a more urgent case. So he would typically have had to go home from there, wait a period of time to then get told, okay, we need to get you back in for a chest CT to look further, some more diagnostics. Because the AI flagged it, they reported it the same day. So it was the first one that they said, oh, it's a priority, let's go and do it. And it had some abnormal findings and they were able to contact the patient that afternoon and book him in the next day to come in for a chest CT.
That's amazing. And it just means it reduces that agony of being in limbo and gets them a faster route to being treated. So I wanted to ask you a question which is a bit left field, maybe. I've done a little bit of digging into your background, which means I've been on your LinkedIn page and nothing else. And I noticed that you had spent 9 years in the British Army. So I wanted to ask whether running a national NHS programme ever feels like the kind of military logistics you were trained for, or is it completely different? I imagine it's quite different. And also, as a sort of follow-up, is there anything that the NHS could learn from how the forces approach delivery?
The army was a big part of my early kind of working career. It helped me and helps me now to think in a certain way around things. I think it naturally instills an element of doing within people. My experience outside of the army has been, I think things move at maybe a slightly slower pace at times because there's always an element of stuff in the army that if you're looking around and there's no one else to make a decision, well, ultimately it's kind of your approach. Now, I don't think that means that people should kind of go rogue in the public sector else. because there are fundamental checks and balances around how we operate. They're very different jobs, but I think there's a lot of sort of transferable skills that I think help.
So I wanted to talk about the idea of moving from concept to scale. The Diagnostic Fund is often held up as a model for how the public sector can move from a good idea to something that's actually live in hospitals. Your programme is a great counter to pilotitis, and that it addresses the valley of death, which both of those things were new terms to me. The valley of death between a successful pilot and full-scale adoption. Take us back to the beginning. What did you have to get right early on that made a difference between this being just another pilot that faded away and something that could be genuinely scaled?
There are probably a few things that have shown our approach as we've gone through this. I think we set out with quite a clear goal around what we were looking to do, and we made it quite clear that that was a focus. We had really good levels of support at the beginning. So the senior responsible officer who led the programme for us, he's our national director for diagnostics and transport. So he's my national director in digital diagnostics. And we made sure that there was appropriate levels of kind of ownership in each of the different local projects that we're kind of running. We use the existing kind of structures that were there from networks, so groups of trusts and the established imaging networks. And then I think we brought everyone together in a sort of a community of practice approach for regular discussions. Because it was a new journey for a lot of people, it was really key that rather than just being a sort of a central programme that said, here's your funding, go and get on with it, and then, we'll ask you in a year and let's hope you've done. We kept quite a close eye and brought everyone together and had a really good opportunity for people to provide that mutual support. And I suppose something that's not that common in the NHS is that mutual support across some of the geographical boundaries. I talked about, trusts in the past, trusts or maybe ICBs had a very, this is us and this is our problem.
Very siloed.
Very siloed, that we wanted to try and break through that and say, actually, by default, you will share your documentation, you'll share your approach, you'll talk about how you're going through things. And I think that really helped because there are some great examples of trusts or networks where they were ahead of others and they were then told, well, share your documentation and other people can then borrow and utilize that and understand the process going through. Because some people were more experienced, they'd maybe done some of those pilots before, but we were very keen that everyone was moving at pace. We didn't want to leave some behind. And I think it didn't hurt either that, since it started, AI has become a thing,
yes,
a really big thing. So it was something that everyone was keen to be part of. But I think it had enough priority to be able to say, look, this is something that we need to do, even with the very, very complex and in some places legacy environment that we have in the NHS.
Yeah, I was going to ask, such a varied landscape with lots of different legacy systems and different governance systems, presumably. Like, how did you navigate that incredibly disparate landscape?
So if you're trying to do anything across those boundaries, virtual or geographical boundaries, I think the shared purpose and the centralisation of coordination is going to be critical. I mean, that's a lesson that we're taking forward into our next period of investment, is that there are some things that are best done coordinated in the middle. And there are some things that are best done, here you go, you can go away and do that yourself. But where we see core interventions, particularly in diagnostics, often they do need to be centrally coordinated and controlled. You could have the draconian approach of going, well, you can't do anything without us telling you can do it in the middle, which is never going to work, but given the size and the scale of the organisation. But at the same time, you won't get that benefit of learning from each other and potentially the economies of scale that you could achieve from a national perspective if you just say, oh, well, all we'll do is just move the money and the funding and just let everyone just make their own choices locally.
Yes.
Because as you kind of alluded to, there are disparities across the organisation. I mean, there's disparities across the country in so many different areas, but we know that if we look at all of the different trusts, there are some that are very, doing okay financially, and there are others that are very troubled. It was really important. In fact, it was one of our objectives for the AI Diagnostics Fund was that we wanted to have an impact in every region of the UK. We can't have it that it's only the wealthy trusts that are able to afford it going forward.
Can't be a postcode lottery.
It's a terrible phrase, but it's one, that really kind of sums up how we want it.
So I just wanted to touch on the patient experience, but from a slightly different angle. You said earlier that 1/3 of all NHS chest x-rays are now supported by AI, which is an amazing stat. I was just wondering, when a patient gets their chest x-ray result, do they know that AI was involved? And does it matter to them that it was?
It's an interesting question. We left it to a local decision for how each particular trust wanted to kind of communicate the use of the AI tool to their patients. And I think there are some really good examples locally where they've chosen the approach to communicate. So in some instances, at the point of capturing the image, have chosen to say to the patient, oh, by the way, we've newly implemented AI, we're using it. And I think there will come a point where it just happens anyway. And in fact, some patients did feedback to people when they were told, oh, by the way, we use AI. They were like, I thought you were doing that anyway. Others chose to kind of maybe do local media approaches. So there's quite a few good examples. You can find some of the videos on YouTube, some wonderful patient-facing and clinician interactions around we're using AI where people have kind of explained it and they've done things on local media reports, BBC, ITV, various things, in order to kind of help spread that message. They've made, announcements on their websites, posters up to say, oh, we're kind of doing these kind of things. So there's a number of different approaches that have been taken around how it operates. And I think if we take anything away from this, I think it's only fair that we're open and transparent about how we choose to use those. But at the same time, what we can't really have is that it becomes its own almost cottage industry to be telling everyone everything about everything that we're doing. So I feel as long as the information is freely available, and this is probably my own personal opinion, as long as the information is freely available, it's not hidden away, and we are open about the tools that we are using and how we are using them, that's okay as an appropriate thing. So the information is findable in that respect, rather than it being ultimately pushed on to people. You can do that anyway, because there are so many instances. I mean, we've all been to a hospital for a diagnostic test, and you get like the A4 leaflet that says this is the test that you're going to do. So there's nothing wrong with saying in that and amending that documentation to say, okay, we use AI in this way, that shape or form. I think that would help to give people a bit more confidence in the approaches that we're taking. And there will always be questions, but making sure that people are aware of this is the way that we've used it. There is still a human in the loop. But it feels like embracing this new type of technology is really kind of the only way in some instances that we're going to be able to kind of make the significant difference to some of those challenges that we know exist, that are communicated in the DARSE report, in the 10-year health plan, in the National Cancer Plan that was published a couple of weeks ago. In all of those, we need AI ultimately to make enough of a difference where we're using it so that it can help us.
So that actually segues really nicely onto my next question, which is about the measurable impact of the programme and what success actually looks like. What does the data actually tell you about the difference that the AIDF has made? And also, how are you evaluating the programme, including costs and cost effectiveness? Is that still underway, or have you completed any kind of evaluation?
Yeah, so there's two elements to sort of the benefits realisation and evaluation. So the benefits data that we've got through at the moment has shown an improvement, not just in the abnormal case turnaround time, which is reduced from about 8 days to about 4, and this is kind of on average across all of the returns that we've had from across the country. This is for chest x-ray, but also overall turnaround times have decreased from about 5 days to 4 as well. But we've also seen a reduced time for a follow-up CT. That's gone from just over 5 days to about 4.5 days. So it's a small incremental piece, but it's still a benefit. And there might potentially in the future, in the long term, be something around, improving the outcomes for cancer patients as well. But we won't know that probably for about another few months yet for our first returns, because you can only get those 12 months after the go live and you're measuring that information. Even a minor improvement in that area, points of a percentage, would still be an improvement.
Before we wrap up, what is next? Where does the programme go from here? And are there use cases beyond imaging that you're watching closely? And also, how do you decide what to prioritise when there are so many potential applications for AI in health?
It's an interesting point because we don't have the funding to be able to do everything. And it's really difficult if you think about, okay, well, what's next? Obviously, there are other areas of diagnostics that we want to have an impact in. And how do you weigh up one area against another one? And you have to look at a number of different areas there, really. You've got to look at the sort of the potential impact, the specific patient pathway that we're looking at, what's there, but across the full length of the pathway, because you might increase something in one area that makes a negative impact further on down the line by choosing to do something. The approach that we took on AIDF was that we, when we were evaluating the different bids and proposals that we'd seen through, we pulled together an expert panel to look at things. And I think we would probably do similar again, bringing in experts from professional bodies. It's important that there needs to be a form of evidence in the first place for us to be able to kind of look at a tool for something where we might be looking to evaluate it and support it nationally or to do a scaled deployment. And there are a number of instances where we see suppliers who have done one pilot in one place and think, oh, well, I've got suitable amounts of data. Why isn't my project being rolled out nationally across everywhere and everyone being made to do it? And I think all of the previous discussion that we've had about how the NHS operates and what it fundamentally means, I think, kind of says that that's not the approach of how the NHS will operate at scale. So at the moment, I can understand it's very frustrating for a supplier, even if they've got a product that's been in multiple places that's shown real benefit, that the approach is still, well, you have to go to all of these different organisations, sub-organisations of the NHS to have that conversation to sell your product. So it feels like there is something that we could do, in that central space to be able to try and make that a bit easier. There is a more joined up approach now around what NICE is choosing to look at, and they are looking at how they can move slightly faster than they have done in the past to be able to support things. And there will be some instances where we want to try and expand our team in diagnostics to be able to deliver more support to people, to be able to answer those questions, to have expertise in there in commercial and clinical safety, so that there are places that people can go to be able to ask the questions that they might have around, well, how do we do this? And we help them.
So if I were a director general at a non-health department, say the Home Office, and I were listening to this and I was thinking, I want to do what Rob and his team have done, what would you say to me? What are the things that transfer from this setting onto other projects, and what is health specific?
The main lesson that people could probably take away is that it is achievable. There was a lot of people right at the beginning, I suppose, probably naysayers who would come around and go, oh, there's no way that you could do a scaled deployment of AI in the NHS. And I suppose the AI Diagnostic Fund is an example of, well, yes, you can. And there are some other wonderful examples of how AI deployments are being utilised in other areas. So I would be looking at those examples and saying, well, is there someone who's done something similar to what we want to do? I think HMRC were doing a chatbot or things like that to be able to provide people support. And I know there's a number of other areas of different, processes that are going on. There is still those barriers. There are always, in every transformational change that you're going through, there is always going to be those people who go, well, I'm not too sure about this, and that will take the time to get there. But we did an approach from the beginning where we made sure that things were transparent, it was open around what we wanted to do, and that we set out at the very beginning how we wanted to capture the information about the impact, so that we made sure that we were able to get it at the end. The worst thing we could have done is we do all of this and then everyone goes, well, how done? And we go, well, we don't quite know, or we've got to go and do some research to find out. Yeah. So be clear about what it is that you're expecting to change as a result of that, and why that is a good thing for your organization. If you have that mindset at the beginning that you're building to be able to measure, you're building your project to be able to measure the impact it has, you will find it so much easier at the end of it to be able to make a decision to say, do we stick or twist? Because, we're at that point now where we know that this has a positive impact on services. There are maybe some other little bits that we need to iron out, but fundamentally it is a good thing. And we're expecting in the next couple of years to continue this and to make this commonplace everywhere.
Well, Rob, that feels like a really fitting note to finish on. So thank you so much for being with us today on It's Personal. And I do hope you will come and be a guest again in the future.
Yeah, happy to.
Jess, what a fascinating conversation. There were so many moments that resonated with me, not only from a citizen experience perspective, but also personally. So where do you want to start with that?
For me, it was that story from day one about the patient in the Northeast who came in for his chest x-ray in the morning and then was contacted in the afternoon and booked in for a follow-up CT the next day because the AI had flagged his scan as a priority. And obviously, Rob was very careful to say that that is not a typical example, but it is a really, really powerful illustration of what this is about. Not, turnaround times or network deployments and all that kind of technical stuff, but actually somebody sitting at home, waiting for results, not knowing, and then just getting their answer sooner.
Yeah, and that totally resonates with our research. We focus very much on pillars like resolution and time and effort being critical to the citizen experience. And having something that's technologically advanced to support that is fantastic in the healthcare system. I can relate so much to this, having been a cancer patient and knowing what it's like to spend hours and sometimes days waiting in a system with a black hole and no information, and your family are texting you, and your anxiety level just increases as a result, minute by minute. And this advancement just cuts all of that out and really focuses on health, but also anxiety and reducing anxiety.
Absolutely. The postcode lottery point really stayed with me too. The explicit objective that every bit of the country should benefit rather than just the well-resourced trusts. That feels like a principle that should sit at the heart of any public sector AI program.
Yeah, I completely agree. And I absolutely loved what Rob was saying about having a shared purpose at the start of any design. It isn't just about designing technology innovation for the sake of it. It's about thinking what you're trying to achieve and genuinely getting that equity of access, which it sounds like he's been able to achieve with this program. And I guess from a sort of KPMG good practice, public sector transformation, the emphasis on really building good communities of practice, on sharing documentation across organisational boundaries, making sure no network gets left behind, and almost designing with an anti-silo culture in mind is one of the things that we hear our clients talk a lot about, that they really want to focus on with that shared accountability.
And that is a great rallying cry for how things should be done. Well, unfortunately, that is all we've got time for on It's Personal today. If you have enjoyed this episode, do share it with a colleague who is grappling with AI design and adoption, or anyone with an interest in public sector transformation.
Thanks so much for listening. Thanks again to Rob Dale, and we'll see you next time.